Hello, welcome to another Research in Progress by the Rough and Narrow Lab. We're glad to have you with us. Today we're going to learn about something very, very interesting. We're going to learn how placental endothelial dysfunction impacts fetal development and health. We have a special guest, Ms. Alicia Tipler, who is going to be talking to us about this subject. We look forward to any engaging questions. Afterwards, there'll be a survey, so make sure you fill it out. Again, thank you for your participation and attendance, and let's have a great time. Alicia, take it away.
Hi, everybody. My name's Alicia Tipler. I'm a fourth year graduate student at the University of Florida. And my presentation today will be on how placental endothelial dysfunction impacts fetal development and health. So just to give a quick overview, I'll talk about the human endothelium, the endothelial dysfunction, fetal programming, placental structure and function. Then we'll go over the methods of the paper, the results, and then we'll end with conclusions and discussion. So the endothelium is a single layer of endothelial cells that line the blood vessel. And so throughout blood vessel formation, we have these periocytes that stabilizes the blood vessel throughout development. So the in blood vessel formation, it is regulated by angiogenesis. And this ensures that there's tightly controlled vascular permeability, which are adherent proteins between the endothelial cells that controls what gets into the bloodstream. And so the endothelium secrete different factors such as nitric oxide that are used by the smooth muscle cells. And this is important for the vasodilation of the blood vessels. And so in the healthy endothelium, we also see this anti-inflammatory state. But on the other hand, when we have a dysfunctional endothelium, there's this imbalance of angiogenic factors. And then we also see an increase in vascular permeability. And so whatever is in this microenvironment, which could potentially be hyperglycemic, things like that, can get in the blood vessel and create this hostile environment of the blood vessel. There's also a reduction in the amount of nitric oxide that's being secreted by the endothelial cells. And so these smooth muscles will constrict the blood vessel more. And this creates this pro-inflammatory state. So overall, when we have a dysfunctional endothelium, it's a key factor in cardiovascular and metabolic disease. And as I previously mentioned, this is characterized by a reduction in the nitric oxide availability for these smooth muscles. And so the blood vessels of the dysfunctional endothelium will constrict more. And so we see blood clots in the blood vessels. And so in the population of African Americans, we see a higher incidence of endothelial dysfunction, and this leads to a worse health outcome for these patients. So in particular, my lab, we work in a pregnancy lab where we study the placenta. So there's this hypothesis or this idea that during pregnancy, the fetus is programmed. And this is called the developmental origins of health. So fetal programming refers to how early life exposures, particularly during pregnancy, can affect the development of the fetal organs, such as the heart, the blood vessels, and this impacts the overall health of the fetus in adulthood. So some of these early insults could be like maternal overnutrition. So some patients, pregnant women who are obese or who are overeating during pregnancy can impact fetal programming. And of course, we have insults like maternal smoking, and this can impact the genetic and the epigenetics of the fetus. Um, Different things like illnesses, so like different bacteria infections and different viruses are some insults. And then exposure to certain medications, such as if we have a pregnant woman that's diabetic or have high blood pressure and they're taking their medication at safe dosages, but overall, this can impact fetal programming. And for environmental toxins, these are things like microplastics that we see now in the literature can impact placental function and also fetal programming. So one insult that's not listed here is maternal stress. And this can impact on many different levels, especially at the epigenetic level in fetal programming. So overall, all of these different insults can impact each organ of the fetus as they grow in utero. This can be the liver, blood vessels, and particularly the brain. And we see like during pregnancy, different wiring of the brain. And later on, we see higher levels of things like ADHD and autism. And then another one is the heart, and we see these low cardiomyocyte levels. And the cardiomyocytes are the heart cells that's important for the beating of the heart. So overall, later on in life, due to these different due to these different maternal insults, we can see things like type 1 or type 2 diabetes in the fetus or the neonate. Also, at a younger age, we see them being overweight or obese, and they show early signs of hypertension. And so overall, this can lead to cardiovascular and also metabolic disorders. So in my lab, we are particularly interested in the placenta. Okay, and so this is cross-section of the placenta. So here, this is the umbilical cord, and this would be attached to the fetus, but the fetus is not pictured here. So inside the umbilical cord is the placental vasculature, and these over time is grown through vasculogenesis and also angiogenesis. And they intrude the maternal blood, creating these finger-like projections, and they are bathed in maternal blood. It's important to note here that the maternal blood and the fetal blood never come into direct contact. But nevertheless, the fetal blood vessels come into indirect contact, a very thin layer between these cell types. So here are the fetal placental blood vessels, and they are lined by these endothelial cells. These cells come in close contact with the cytotrophoblasts, which are then differentiated to become these single nucleated syncytiotrophoblasts. These syncytiotrophoblasts express different glucose and amino acid transporters that are important for glucose and amino acids and protein transport to the fetus. So the overall function of the placenta, of course, is nutrient exchange and also the diffusion of oxygen. So the oxygen that is in the maternal blood that bathes the villi is diffused across this thin layer membrane, also termed the vascular syncytial membrane. And this is where the fetal blood vessels can uptake that oxygen. It's also important for hormone production, such as HCG levels, and this is the levels that they use during, pregnancy tests. That's what the pregnancy test hormones measure HCG levels, which comes from the placenta. And immune protection. The placenta highly regulates what comes into the fetus. It doesn't let any and everything come into the fetus. So there are different cell types of the placenta, and any area during development or gestation of pregnancy can impact the placenta and causing this placental insufficiency. There's also things such as preeclampsia, which is constriction of the maternal blood vessel. So here, this is a maternal blood vessel, and you can see it's highly dilated, and it allows the maternal blood to bathe the villi. But in preeclampsia, you'll see that this maternal blood vessel is constricted, and so the flow within the villi space is very fast. And so this can damage the syncytium. And then also we see fetal growth restriction. So the decrease in the amount of oxygen and also the amount of glucose and amino acid transport that is getting into the fetus blood vessel can impact the growth of the fetus. We also see things like placenta accreta, which is when the placenta embed too much into the maternal decidua, and that causes problems with detachment at term. So this can cause hemorrhaging. We also see gestational diabetes. This is diabetes that occur during pregnancy. So a mother might not have diabetes, but once she go in and she take the glucose tolerance test, she finds out that she has gestational diabetes, and this is due to the immune response during pregnancy. And another thing, what I focus on in my lab is how we're still learning more about it, but we see higher incidence in placental dysfunction and cases of congenital heart defects. So this is a population-based study from 2011 through 2017, and this data was taken out of California. And they wanted to determine whether maternal insult impacted the amount of congenital heart defects. So this study included over 2,000 non-Hispanic white infants, which were used as the reference group, a little bit over 5,000 Hispanic, and then about a little bit over 600 non-Hispanic Black infants. Maternal placental syndrome was defined as the presence of one or more of the following, which would be maternal preeclampsia, gestational hypertension, or placental abruption. And then maternal metabolic syndrome was defined as the presence of one or more, which was pre-existing diabetes or gestational diabetes, a BMI of more than 30. And so what we found was that in the Black patients that had a severe CHD subtype, there was incidence in the maternal placental and metabolic syndrome with a higher incidence of CHD. They also found that the non-Hispanic Blacks that had CHD also had, they were small for gestational age, which this is SGA, and they also had a higher incidence of prematurity. So this brings me to a paper that my lab published, which is different than the paper that we actually were originally going to talk about, but it still holds weight in the endothelial dysfunction and cardiovascular. So from the paper, we hypothesized that placental tissue from congenital heart defect is immature, and is characterized by morphological and vascular abnormalities in some cases. And these findings are more severe in those cases with growth abnormalities. So as you can imagine, I didn't previously mention this, but um, no matter the race, when fetuses have congenital heart defects, they do have a higher incidence of being small for their gestational age. So in this paper, they recruited patients at Cincinnati Children's Hospital. They had an N number of 18 in the controls, and the controls didn't include any previous maternal syndromes such as diabetes or hypertension or things like this. This was uncomplicated pregnancies. And then they had an N number of 16 from hypoplastic left heart syndrome. And hypoplastic left heart syndrome is a severe CHD subtype. So at term, which was more than 37 weeks, we collected the placentas, and then they embedded the placentas in paraffin wax, and then they did either hematoxylin and eosin staining to look at the terminal villi, or they looked at vascular syncytial membrane, and they looked at syncytial nuclear aggregates. They also use these blocks to do immunohistochemistry, and they stain for CD31, which is an endothelial specific marker. So in those villi, you can actually see the blood vessels in the villi. They looked at Ki67, which is a proliferative marker. So they looked at Ki67 because at term, the placenta should be fully functional because they just gave birth to a baby. So they shouldn't still be proliferating. They also looked at FILC1, which is VEGF receptor 2, is an angiogenic receptor. They also looked at leptin signaling. So this is figure one. Figure one is a hematoxylin eosin staining. So A is control and B is CHD. Yes, from the HLHS placentas. So these yellow asterisks are the fetal blood vessels. Um, and what they saw was that there was a reduction in the amount of fetal blood vessels in the terminal villi. There also was a reduction in the terminal villi in the CHD subtype. In B, they have outlined here. This is fibrin deposition, and increase in fibrin deposition basically shows that there may be changes in the blood flow into the placenta, and so it damages the syncytial trophoblast of the placenta. And so as a protective mechanism, this fibrin grows, trying to protect the placenta. So this is what this outline is showing. These black arrows here are showing the syncytial nuclear aggregates. And so whenever there's aging of the placenta or like kind of get tired, they produce these nuclear aggregates. And so that's kind of like not what we want, because then it continues to reduce the amount of oxygen that's getting into the fetal blood vessels. So here's a table of the overall different factors that they looked at. And as you can see, there was a reduction in, like I said, the syncytial membranes, the vascular area, and the density of the blood vessels. So I know that they say vessel density, but this is really just the amount of blood vessels per high power field, not actually like inside. That would be the area. And then the number of terminal villi. And I don't think I had mentioned before, but there's different villi types depending on the branching and non-branching angiogenesis. But at term, there should be a lot more terminal villi. And so that's what this is counting. And so they count it based on the size of the villi. So it says like less than 80 microns. And then the vascular syncytial membranes is also significantly reduced in the CHD subtype. They next looked at the proliferative activity, which showed that in the in the CHD subtype, there was a lot more terminal villi that had proliferative activity in the CHD subtypes compared to the controls. And so this is figure 3, and this is the CD31 staining. So as I previously mentioned, CD31 is a endothelial specific marker. And as you can see in the terminal villi, you can see how it outlines the blood vessels, and these are the fetal placental blood vessels. So in the CHD subtype, there's a reduction in the amount of blood vessels, but also in the area of the vessel. And this shows that at the end of term, there's definitely dysfunction in the endothelium. So they next went on to look at leptin signaling. Leptin is involved in angiogenesis, and it's important during fetal development. And so panel A and panel C is from the controls, and panel B and D is from the CHD. And so you would kind of expect that leptin would be decreased if there's decreased angiogenesis. But the placenta has this like fun way or like smart way of trying to compensate. So basically what this is showing is that in the CHD, there's an increase in leptin signaling. And so during at term, the placenta is trying to increase the angiogenic factors and things like that, the signaling. So it can try to get more terminal villi and more blood vessels to try to increase the amount of glucose and amino acids and oxygen to get to the fetus. Then they also looked at VEGF receptor 2 expression. And so what they wanted to look at was the localization of the receptor. And so they saw that it was localized to the fetal endothelium, which was good because this is where angiogenesis take place in the placenta. And so they seen that it was a reduction in VEGF receptor 2 expression in the CHD subtype. So overall, from this study, there's the placentas from HLHS, which is a severe CHD subtype. They have this immature village tree. So from the H&E staining, we can conclude or discuss that there's an increase in fibrin, and this overall decreases the amount of oxygen that can actually be transferred to the fetus. And then there's a reduction in terminal villi. The reduction in the terminal villi is that there's not even blood vessels around that would be able to even uptake the oxygen and the nutrients from the maternal blood. And from the IHC of leptin and VEGF receptor 2 and also the CD31, there's an imbalance in angiogenesis in the CHD. But we do see that the placenta is trying to compensate for the reduction in oxygen and nutrients. And so all of these basically shows us that the in utero environment of the placentas in the CHD subcases are hostile. They're very hostile. The placenta is desperately trying to compensate. They're trying to get more oxygen. And this overall creates like this hypoxic environment. So you can imagine like um they are getting oxygen, but not the amount of oxygen that they need, especially during the later half of pregnancy, where the fetus is growing and growing and growing. Like this is like a 5 to 7, sometimes 8 pound baby. They need a lot of oxygen, a lot of glucose, a lot of amino acids to grow, and to develop all of those different organs. So in cases of CHD, um, it's not just the heart that needs all of this. This is all of the different organs. So the heart and the brain, which is very important. Um, so that's what this data shows. So there were a few limitations. So these placentas were collected at term, so they could only investigate like what has already happened. They don't know what's going on at the beginning of pregnancy, so they really can't just say like what is causing um the heart defect. They just know that the placenta is trying to compensate for this dysfunction in angiogenesis. So I think they're moving towards maybe trying to, I don't know, do other type of sampling to get placenta tissue during pregnancy. That can be pretty difficult in today's world where they don't really want anybody touching pregnant women or women consenting to these type of studies. Um, and also another limitation was that they only collected placentas from the HLHS cohort. And so this is a severe CHD subtype. And so it's very rare for them to even have these cases. There are other subtle CHD subtypes that they could potentially include, like septal defects, where it's a lot more patients that they can include in the study, and they could potentially have these similar like abnormalities in the placenta. um I wouldn't know how long it took them to collect these placentas, but since it's rare, I'm pretty sure it took them a while. But I'm pretty sure they go like more subtle. They could potentially collect more CHDs. There are like at least 10 CHD subtypes. So in the future, I think they should be collecting like all CHD subtypes. Just to see what they placentas look like, if these placentas could be treated, etc. So thank you. That was my presentation. And do anybody have any questions?